So good afternoon, everybody. Everyone's just taking their seats. So it's a great pleasure to be here. My name is Peter O'Kane. I'm a consultant in Bournemouth in the UK, and my co-chair for this session is Mohamed Egred, a friend and colleague from Newcastle in the UK. We have a fantastic panel. We have Kurti from Mumbai, we have Peter from Lublin, and we have Alfonso from Madrid. This is going to be a great session discussing laser. I hope you're in the right room. Just hands up before we start. Who in the room has access to a laser console and laser catheters for coronary work? So a few, but not many. So it'll be interesting. So for those, let's hope we can convince you all to go and buy a laser machine at the end of the session. So my role to start off with will be just to discuss what we're trying to talk about in this session and get the overview and objectives. I'm lucky enough to be part of what we describe as a task force, and what you're going to see today is two very nice cases that will hopefully give you some understanding of the laser, how it works in coronary artery disease, and tips and tricks to make it as efficient as possible. Laser stands for light amplification by stimulated emission of radiation. We're going to talk about the coronary circulation. You can use it for other mechanisms, but there are 4 coronary catheters to be aware of. The 0.9 is the one we use the most commonly. It's for CTOs and tight lesions. We get 80-80, which is, I'll explain what that is. That's the highest settings. 10 seconds of lase-in and 5 seconds rest period. The other catheters require slightly bigger guide catheters and have a shorter lase-in time, but are equally effective for certain indications. It's a multi-step mechanism of action. Laser is very interesting. It's ultraviolet light initially, which is of 308 nanometers, so it's very safe. Then you get the sonic wave that cracks the more fibrotic calcific tissue. And then you get this cavitation effect where the catheter almost forms an umbrella. It macerates material, produces tiny particles that don't cause any problem with no reflow. So this first step is the atherectomy, is how it breaks the bonds, the UV light, very shallow penetration depth. You get this sonic wave that then penetrates into the tissue in a sort of perpendicular fashion. And you can imagine how this is going to break the tissue and crack the calcium and crack fibrotic disease. And then we have this maceration effect of the cavitation breaking down the tissue and then reforming this constant vapor bubble. We use it in saline to protect the vessel most of the time against dissection and against perforation. But in some occasions, in perhaps 10%, 5% of cases, a mixture with contrast is quite useful. And actually, this is a great experiment that's recently been done just to show how if you use it in a contrast mix, you actually get more efficacy, and you get pressures over 50 or 100 atmospheres, which is quite amazing. And it not only produces that effect in terms of the sonic wave, but also the ultraviolet light effect and the cavitation effect are all enhanced with contrast. When you're using laser, be a slow driver. Move it slowly through the vessel. Don't go fast. It won't work otherwise. And these settings, the first setting you've got is the fluence, that's the energy you're delivering. You can see how it changes the cavitation bubble size. And if you've got harder tissue, you want perhaps harder settings, higher settings. The second number is the repetition rate, that's how frequently you're delivering the pulses, and you can change that up to 80 hertz. There's many papers that we've all published, all of us on the panel. This is a simple summary that we did many years ago. And I think 2 key indications is a non-crossable, non-dilatable lesion. That's really key. And if you've got stent failure, so stent under expansion or diffuse stent restenosis, laser is incredibly helpful for those types of cases. And you're going to see examples. This is examples from my lab. This is you can see an LAD stenosis with a non-expandable balloon. The OCT shows, in this case, more fibrotic tissue, which was very resistant to balloon. Laser, job done, very effective. Finish with a stent and DCB, the rest of it. This is a non-crossable lesion. Again, this is quite a contemporary case. You can get a wire down, you can't get a small balloon down, you can't get a microcatheter down. The great thing is laser works on a standard 0.14 wire, so it means you can use laser across the whole of the proximal vessel. The imaging shows you some disruption of the calcium, as you'd often expect, and you can get a great stent result. So it's really efficient, easy, and it will save you time and potentially money, and it's safe. We're putting together a consensus document that we'll all contribute to, and that will come out very soon. But I'm going to leave you with 2 great presenters and great cases, with Kurti first and then Alfonso. And I hope this session will be very interactive, and we'll get some questions from you later on. So I'll hand over to Kurti without any further ado. Thank you.
Thank you, Peter. And all my colleagues on the dais, thanks for this, and thanks for this opportunity. Can I have my presentation up there? So quickly present the case, and then we can have a discussion. This is a 1997, this 77-year-old now gentleman who's come with angina and a strongly positive stress test now. In 1997, had a CABG with a lima to the LAD and a radial graft to the OM. 2009, unstable angina, RCA critical, underwent an angioplasty with 2 tandem stents, 3024, 275, and 24 back-to-back in the RCA. He had angina 2 years following, but kind of managed it medically till it got to the point where the angina was incredible. And this time the RC was occluded with an ISR. This was done using a retrograde approach. And further stents placed 27538 and 27524 within the previous stents. These were optimized using a very high pressure balloon, in this case an OPN 30 at 25, and that's what the operator notes say. He's come with angina, as I mentioned earlier, with a strongly positive stress test, and this is his angio now. So we can see those two multiple layers of stents. We can see unexpanded segments on the fluoroscopy. We see that the RC is totally occluded after that second RV branch and a long segment missing. A few mentions about the 217 PCI was a retrograde approach, complicated by hemodynamic instability during the procedure, which not much mention about except for this one line. And I want to bring to your notice again this ultra-high pressure balloon dilatation with a 30 balloon at 25 atmospheres at that time. I'll leave you with this image to kind of ponder on. We used a fine cross microcatheter with a UB3 wire, and we realized that the IVUS catheter would not cross, a small balloon wouldn't cross. So I'll leave you with this question.
So, very nice case. Mohammed, how would you manage this in your lab?
Before I answer this question, I'd like to see what the audience would think. Who of you would go for scoring balloon or cutting balloon as first approach? Who would go for rotational atherectomy, which will require a special wire, which may or may not be crossed, obviously, with the microcatheter? So one hand. And any other approaches? If there's a microphone, if somebody wants to make any comment or comment on this case, please. Because
There's some votes coming in.
Yes. So a split. The people who voted others, can somebody just volunteer and give us what other approach they will do? Come on, we have a shy audience here. Come on. Somebody tell us what other approach. No. Okay. I mean, obviously, now it's changing a little bit here. I think there are multiple approaches. Of course, we all know about uncrossable undilatable lesion. We start with this step-by-step, i.e. small, low-profile balloon, microcatheters. However, you could spend a long time trying to do this. And if you have if you want to use rotablation or orbital atherectomy, it requires a special wire. You have to deliver the wire before you do the rotablation. So if you deliver an angioplasty wire and you cannot deliver anything, the only option you will have is probably laser. Here there are some more complicated where you could go dissection, re-entry, and crush the uncrossable lesion from outside, but that's quite high end and not everybody's going to be able to do it. And you run the risk, even in experienced hand, to lose the artery completely. So if you pass an angioplasty wire, you can't cross the lesion, laser is probably your best bet.
What do you guys, anyone else, what do you think?
I'm totally agree. First, we are working with laser on a normal angioplasty wire. It's very practical, it's very easy, and it's facilitate the case. The second, we can make with laser catheter very nice pathway for other devices. It could be balloon, it could be other devices, even in the worst case, the devices with a different approach. And I think it's in my lab, I'm totally agree with Hanet. I'm going with a laser. In this situation, with a laser, probably the 0.9 millimeter, it's with a very good profile.
Alfonso, would you have the laser machine already booted up at the start of the case?
Yeah. I would have done that. I think in this case you have two problems. One of these is the lesion is uncrossable. Even a small balloon didn't cross, so you have to make it crossable. You can stack a micro and try to cross the rota wire, the Viper wire, or use laser. And in addition, afterwards you have to dilate this lesion. So probably the combination of these two problems and the solution could be the most efficient technique, in my opinion.
Thank you very much. Question and comment together. First of all, we cannot see the distal vessel. So is there any CTO there? I mean, if you use rotational atherectomy or crown atherectomy, which is probably more less, let's say, aggressive, you cannot, let's say, go through, let's say, the distal vessel, because you see I saw that the wire couldn't cross the distal vessel. So whatever you have to do, I think you have to do it till, let's say, the last stent when you see flow. Afterwards, it's, I think, debatable what you should do. And the question is the following. Does anybody use the crown atherectomy for this case? Is it more convenient? Is it easier to...
Sorry, use what?
The orbital atherectomy.
Okay.
So,
Well, I think you're going to probably address both of these. I think you're right about understanding the distal vessel before you attempt anything, really. You want to make sure you know the wire's in the right place. But you're going to show that, I think, coming
that's
up.
right. So the wire was in the right place. We checked it with a retrograde angio, but we kind of skipped it out because we had this limited time. To answer the question on orbital atherectomy, it's a relative contraindication in ISAR, because if there are struts around, you can get entrapped in that. What we did was we had a guide extension catheter down, and we had a 0.9 fiber. You can see that we used saline irrigation. We laced in a saline medium 7 trains, 5,566 pulses delivered there, and then proceeded with an off-regulation use, which is with contrast. We used undiluted contrast in this particular case with 3 trains at 2,073 pulses delivered, and we made sure that there was an effective passage of the laser catheter into the distality of the artery. So then we did an IVUS run, and this IVUS run I could kind of run through the whole thing, but to just cut the long story short, based on the landing zones at either ends of the artery, we kind of figured that the expected MSAs should have been around 7.1 at the distal end of the stent, somewhere 9.5 in the mid segment, and around 11 is at the proximal end. What the previous operators achieved was 3.65 and 3.74. So you can see those 2 images there of severely underexpanded stents in spite of the high-pressure 3.0 Opian balloon dilatations that they did at 25 atmospheres. So this is a serious inexpansion of stent in an area where an attempt has been made by a very high-pressure balloon. And the beauty of this laser is that it allows us to assess this without distorting this expansion index. That means if you were to use a balloon, you wouldn't be very creditable about your underexpansion because it would have expanded that area a little bit. Once we did that, I mean, what did laser do in this case for us? It made the uncrossable crossable pretty quickly, identified the unexpanded segment without deformation caused by an initial balloon dilatation, and satisfactory ablation of the luminal tissue between the layers of stents and the peristent area with the contrast. We then followed it up based on the IVUS and what our expectations were for the final MSA. We decided to take a high-pressure balloon at 18 atmospheres and demonstrated that it completely expanded in 2 fluoroscopic views through the entire length of the area. That was the target. And then did an IVUS, repeated the IVUS. We made sure that the IVUS interrogated the same images by looking at the distal end of the stent and then measuring the size and length of which we needed to select a frame to be consistent with a pre and post assessment. We found that the artery, if you can see that little column there, is 11.1 millimeters proximally the landing zone, which means a fairly large artery, more than 3.5. And what we were done to the unexpanded segments was raise them to 7.87 and 8.4. These are the two runs simultaneously. I don't know why both are not playing together, but it just shows how beautifully the luminal space has been cleared and the stent expanded. When we put it in a tabular form, the actual MSA that we had prior to just after lasing was 365, and we were able to enhance it to 8.41, 7.84 respectively. This is we've done these cases before in a pre-LCAD era, and this is a very large gain in MLAs for these two layered stents and ISR. We then followed it up with 2 drug-eluting balloons, and this was that was our final result. A long-term clinical outcomes with this is a little paper that I want to talk about, which came from the U.S. 81 cases, very discrete lesions. However, I mean the point that paper made was when we use a PCI with ELCA as against not using ELCA, the MSAs were significantly improved. Just a little mechanistic of why this happens if this is a cartoon which represents the lesion, you can see the dark browns are the calcium intrastent, peristent, and when doing a balloon dilatation, you expand the lumen, but very seldom crack the calcium, which is so abutted against the stent struts. It's difficult to crack that. It's difficult to modify the calcium, and calcium fracture is not seen frequently. However, when we use ELCA with contrast, it's like a little controlled explosion inside. And as Peter said, this could be as high as 100, 120 atmospheres barrel pressure that we create, which not just ablates the luminal stent area, but it also kind of goes into the peristent segments, allowing for better extrusion of the tissue with the subsequent balloon dilatations. Just to tell you our view on how we position laser in this group is for this particular case, it was diffuse. There was a CTO, it was calcified. It was underexpanded DS that we saw. ELCA would be our go-to device for this as a first one, and we recommend that strongly. I recommend that strongly. And the NC balloon, a scoring balloon, or any normal balloon that you would choose after that to make the next dilatation, and you can proceed to a DB. Seldom we might need to go to other devices to kind of further treat those deeper layers of calcium. That may be an option. And in general, I mean, this is a complex slide, but if you look at it, the focal edge nonsense, starting from the leftward down, leftward and then going right, the focal edge non-CTO, non-calcified, you could treat with simple non-complied balloons or scoring or cutting balloons and proceed to a DB or DS, what you choose, or alternatively, some may require an IVL and then you go down the same path. But when you start seeing these diffuse disease ISRs, I do recommend, I do think that the ELCA has an edge in getting better MSAs, so it's better used. Of course, crossability and uncrossability may play factors in how you choose your devices. And besides DB and DS, I mean, some may opt to then send these patients for intravascular brachytherapy. On the left are just those factors which influence decision-making in our tree. And the take-home message would be that it's a simple, can be used on a workhorse wire. Rotational atherectomy and orbital atherectomy require specialized wires. Orbital atherectomy still has to gain an indication for ISR. The learning curve is small. If you can handle a microcatheter, you can do an ELCA. Ablate neointimal tissue within the stent with saline and the peristent segments with contrast, reduce procedure time, making PCI more efficient, and ELCA-assisted lesion preparation may be associated with better MSAs. Thank you.
So that's perfect presentation. We've got 5 minutes for Q&A, and while we're doing that, if Peter gets up the smart screen, we're going to look at those IVUS images. Any questions from the audience at this point? So I think what we've seen in that case, brilliantly illustrated, is how effective it is for 2 indications, under expansion of stent and also diffuse stent restenosis, all in one case. Peter, do you want to show us on the IVUS those changes?
Yes, okay.
With the smart screen.
Okay.
Yep.
Hello? Okay, it's fine.
You're on.
Excellent. As you see, it's just the case was presented, excellent case presented by Kriti. It's a situation just after the ELCA passage. It was 0.9 millimeters catheter. I just memorized that it's the most powerful catheter possible to achieve on the market. It has a very good profile. It's a profile which is comparable with a drug, with a non-compliant balloon. It's a very, very smart when it's going with a very good crossability, and we have achieved a lot of energy. What we have achieved here, as you see here we have we're removing a plaque inside of a stent. The first, were ablation effect. The second, as it was presented in Kiriti presentation, with some very great force of cavitation force, we can create the force which can disrupt also the calcium inside and outside of a stent. It's very important versus to the good lesion preparation and to the good expansion of a stent or other part of a stent, different layers of a stent. And here it's a final result. Very nice picture with very great improvement of MSA, and as you see, the result is very, very convincible. The take-home message from this presentation, in my opinion, is first, it's very safe, it's manageable, and it could be used in very this kind of situation on uncrossable lesions. My questions are for audiences, because probably you would just ask me about safety reasons. How many people just perform PCI, normal standard PCI in an audience? All? Majority? No. PCI. Do you perform PCI? Of course. No, thank you, because I was a little bit surprised. Okay. Do you have some dissection or sometimes perforation during PCI? Yes, of course. It's a normal, yeah? And now I can say you that according to the new data, the last 5-6 years, the level of dissections and perforation during PCI and ELCA, it's the same. It's not a reason to be aware. Of course, a lot of people just memorize that 15 years ago it was different. Yes, it was different because they used a lot of laser in a cases were not very suitable for a cases and not follow the rules. It was the same like with BRS. It was the excellent tools, but used not for such cases which was produced for. And the reason why I think congratulates once more Kiriti for a very nice presentation.
I think, I was going to say, I think that the key on that slide is that space between the stent layers, which if you think about other alternative devices, you can't remove it. There's nothing else out there that's going to get rid of that material between stent layers. And that's where ELCA is different, because it does get rid of it. And that's why he's got such a great result with stent expansion. You can't even see there's multiple layers there. So we're on time. We'll hand over to Alfonso and hand over to you.
Thank you, Peter. Now we have Alfonso is going to show us also one of the important indications for laser and tell us about an uncrossable lesion. Alfonso, take it away.
Thank you, Johannes. Thank you for having me here. I'm going to present a simple case of an uncrossable lesion after the case from Kirti. This is a 59-year-old male with dyslipidemia and hypertension who suffered from a stable angina, CCS3 class, underwent a positive treadmill test, and had normal ejection fraction without wall motion abnormalities. The lab tests were also normal. This is the first angio without significant lesions at the left tree, and with a CTO in the mid-right coronary artery. So with this information, we decided to perform a PCI of the CTO of the right. This was our plan by radial approach, 7 friends, starting with antegrade barrier escalation, retrograde biceptal, CDR, you know this stuff. So this is the initial bilateral injection that changed a little bit the plan. You can see that the occlusion is quite long. You have proximal disease, some ambiguity at the proximal cap because some tiny branches arise from that point. And we started, I'm going to resume the case. We started antegrade. We failed with several wires. We changed fastly to the retrograde by the septals. Ascion black crossed easily to the distal cap. However, the retrograde microcatheter, as you can see here, couldn't cross the septal connection. So at that point, as you can see, both wires, the antegrade and the retrograde one, was too close. So before doing more advanced techniques, we tried again to puncture with the antegrade wire, a Gaia second, following the marker of the distal wire. And we succeed. If you see the still image, every time we push with the antegrade wire, all the antegrade material go back, the microcatheter and also the guiding. So we had a lot of friction there. But crossing to the true lumen with antegrade wire let us thought that almost was done. It's like when you score a goal in the minute 70-something in the Bernabeu and you think everything is done. However, nothing else could cross over this wire. Nothing else. We had the Gaia second in the true lumen, small balloons, the microcatheters, a small microcatheter, a turnback spiral, and you can have this feeling. And now I have a question for you. What is your next move? Use an ultra-low profile balloon if you have. Stop and think about CABG. It's a young patient with a CTO, a very big vessel, and limited angina. Or ELCO, another technique.
So if you could vote, please. And while we're voting and waiting for this, any comments from the audience? Or if I ask my colleague here to make a comment, how they approach this?
Okay. So I think, Alfonso, great case. We see this all the time. You struggled, spent 30, 40 minutes, an hour to get the wire across, and then another 1.5 hours to get the first balloon in to dilate, and then by then you've used a large part of your inventory of balloons, right, with a lot of other devices. For me, you set yourself up for an ALCA really and make your life simple. We've been through all the other steps, and I think this is... What about you, Poitro?
Yes, I agree. I think that CTO procedures is quite long by definition, and I would be conclude as quick as possible this case. Of course, I'll start with a small balloon, but it was not crossable. If it's not cross, I'm going with laser. What the advantages? Because it was very tricky and very difficult to cross the Gaia. It's impossible to cross with, for example, rota wire. It's impossible. You agree with me, and I suppose. But in this situation, laser is the best option.
Yeah, and that's the whole point about this. If you have comment, if you come to the microphone, please. That's the whole point about using the rotablation or orbital atherectomy. These require a special wire that needs to be delivered distally to be able to use them. And if you can't put the microcatheter or can't put the balloon, then it's very difficult. Please go ahead.
I'm from Romania, Târgu Mureș. I have some backgrounds. 2006 and 2012, I performed with this device 100 laser intervention in coronary artery and maybe 300 in peripheral artery disease. After me, if you cross with guide wire, and maybe you can tie it with very small balloon because laser is cost in Romania cost, maybe in Spain not. Try to open with other my greatest balloon, 2 millimeters, but never happened that I used laser to not cross. Laser is the best after me who performed this method and used, but I lost because the company is not was good. After me, because I have great advantage in interventional cardiology, the best method is laser.
Well, thank you. That's quite a clinical experience that shows you. And this is what we're trying to send the message out. Not everybody has laser, but if you understand how it works and the efficacy of it, and that it really builds you out, because How many of you have had this scenario where you put the wire down and you tried microcatheter, small balloon, and to deliver to rotablation, whatever you want to do, and you're not successful? Show me your hand, please.
That's right.
Exactly. So this is where you have to be thinking about what else can I do, and this is where this comes in. You put the wire down, nothing works. What can you do? Alfonso, please go ahead and tell us what you've done.
Bernard. Okay, I'm going to start with a video. So at that point, probably the laser is the most efficient option because, as you know, is the only plaque modification technique you can use through a 6 French and a conventional guide wire because rota or orbital needs specific wires, and you need to cross with a microcatheter to do the exchange. We use this CDG technique, the practical technique of using a mosquito just to maintain the laser catheter here. And we have to do both things. We have to calibrate the console. This job has done before by our nurses with a non-sterile catheter, and then we need to calibrate the catheter, the sterile catheter. So this second part is performed by the operator, the person in the scrapping. So we have a pedal here. So all the people in the cath lab should be with the glasses or without looking the laser. And I'm going to calibrate it, probably there. Calibration, okay. So stand by. And the major advantage of laser in this setting is that we can use this catheter, this laser, the catheters through any 0.14 wires. So this is the thing that we did. We advanced again a guide extension catheter. We did it before to try to cross the microcatheters and this stuff, and successfully. So we advanced again the guide extension catheter, and you can see the radiopaque tip of the 0.9 ELCA catheter advancing quite slowly, as Peter said before, quite slowly to administer the energy there. And we didn't know if we cross intraplaque, extraplaque, so we only wanted to make the uncrossable lesion crossable. So we apply these settings, 60 millijoules per millimeter square, 60 Hz, only 1,300 pulses with saline. And after that, if you pay attention, you can see a 3O balloon crossing like an in butter. I will put the video again because it's quite fast. And after that, the balloon is expanding quite good in 2 orthogonal projections, as you can see here, in the part that was uncrossable. So immediately after laser, you can advance a 3O balloon, a non-compliant balloon. No? I will show you again the crossing of the balloon. Okay, so at this point, your feeling change. You think that the case is really done, and you just need to dilate a little bit more, put your stents, confirm with IBUS, optimize everything, and that's all. No? So why is a lesion uncrossable? Just making some philosophy. Because the lesion is complex, because you are not using the proper techniques or materials, or because you have no patience or training. In the past, we know that probably rota has been the most used technique in this scenario, but you have to cross, as Mohamed said, the rota wire, and sometimes you cannot cross a microcatheter. So ELCA is complementary to all these techniques, but also can be a powerful option since it can be used by any standard wire. This is our algorithm in Uncrossable CTO. I'm going to simplify for you. You have the optimal support that sometimes include treating the proximal part of the vessel, and you cross a wire, you can advance a small balloon or even a microcatheter to change the wire and complete your PCI. But if nothing else crosses, you have a problem, and you have 3 options. You can do very specific techniques, but there are 3 options. Use an ultra-low profile balloon, try different microcatheters, try to advance, or use ELCA. Now in Spain, the use of ELCA has increased exponentially in the last years, and this is not only Spain. This is US, the blue line. From 2014, more or less, the use has increased exponentially. When we use ELCA, more or less 40% in uncrossable lesions, more or less 40% in undilated lesions, and in some cases in thrombotic lesions. And probably CTO is the best example of an uncrossable lesion. And in these cases, in an uncrossable CTO, in the Progress CTO registry, There are probably 10% of cases like that, and laser was the most efficient technique here. When we look for a specific series of uncrossable lesions, this one of Soledad Ojeda, a laser has a success rate in this lesion near 90%. Obviously, it's complementary to other techniques as ROTA. In some cases, like this, you have an uncrossable and undilatable CTO, a lesion. You try to cross a balloon, you cannot. You try to cross a micro, you cannot. So you need ROTA. You think you need ROTA, but you need to cross the microcatheter there. So you use laser, in this case with contrast. Afterwards, you can cross a microcatheter, the ROTA wire, do ROTA, and finish the case. So this is our proposal for this kind of lesions, balloon uncrossable lesion. Of course, you can do the conventional strategy, low profile balloon, increase joint support, or more aggressive techniques like Carlino, granuloplasty, or dissection reentry. But laser could be a good alternative because could modify enough to cross everything afterwards, even if the laser catheter cannot cross. So it's quick, predictable, and prevents multiple materials usage. So my take-home messages are similar than Kirti ones. ELCA is a useful technique in different complex PCI subsets, balloon failure, and also thrombotic lesions. It's easy, it's effective, it's safe. Could be the most efficient technique for true uncrossable lesions in which you cannot cross even with a microcatheter, and you need to cross something through a 0.14 wire. And of course, in my opinion, it's complementary to other techniques. Thanks for your attention.
Thank you, Alfonso. Great presentation. As you gathered, Alfonso supports Barcelona, I think. Right? Anyway, I think there's a few things here just for the audience. When we talk about the pulses, this is what the machine will give you, how many pulses you delivered. Often it's probably not as important. It's about kind of treating the lesion. The second thing, laser quite often does not have to cross the lesion. Even activating the laser at the lesion where it's not uncrossable, it will change the complexion of the lesion, which will allow you to put the balloon in. And some cases you have to do like an inchworm. We use the laser, then the balloon, the laser, the balloon, until you cross the lesion. So don't think just if the laser doesn't cross, it has not made an effect on the lesion. So it does. Peter, we're going to show us some...
Yes, it's very important. First, I'm very fond to perform the good angioplasty, but with the shortest possible time. Just what Mohamed said, just look, it's only 1,315 pulses. The people who use a laser in this case know that it's a very, very small amount of energy. It's a very fast procedure. And the case, what was an excellent case presented by Alfonso, will show you that it's a very useful technique which could be work with other techniques together. And of course, we can what we can gain with this technique. In this case, and you see, it was very, very, very long lesions. And as you see during an angioplasty, for a first point of view, it's going nothing. We just see that this just a small black tip, it's going down. But what Mohamed said, it was a lesion preparation. What we are facing now, that we must think about the perfect lesion preparation. It's not only like for a BRS era that it was necessary to perform like that. I think that now we must perform all lesion as much possible to prepare for a stenting. And this modality like laser just give you the such opportunity.
Thank you. You have a comment or a question?
3 short questions. First of all, is it safe to use ELCA subintima?
It's a very good question, in my opinion. We don't know, but you don't have another chance. So this was my point in this case. I use saline instead of blood or contrast, and just a small amount of energy just to make it crossable, because we don't know if we cross extra plaque or intraplaque there.
Exactly. Second, do you encounter any bradycardia? Do you need a pacemaker lead in advance?
Not at all.
No. And the third question is, if you cannot cross with a wire, can you advance a laser till the tip of the wire in order to modify the plaque and cross it with I don't know.
I'm gonna step. Yes, I have done it. It's off-label. You have to be really experienced with this. I've done it with CTOs very frequently, where I cannot cross the proximal cap, and I have used laser with the wires not there. But you have to be really safe to make sure where you are, and you activate the laser in that area. I'm not advocating this for people just to go and do it that way. Absolutely not. When you get the experience with it, you might be able to do it, but yes, it can be used. And I know that some operators in the USA have started doing the same. So it does work that way. Sorry, yeah, just a comment. Go on, Ibrahim.
Hi, sorry, thank you. That's very elegant.
Speak in the mic, please.
On the mic.
Yeah.
Okay. Sorry, can you hear?
Yeah.
I'm Ibrahim, one of the fellow at Freeman Hospital. Just my question to you, when you come to heavy burden thrombus, would you recommend, I mean, in a STEMI situation, would you go straight forward for laser atherectomy, or you prefer to use like conventional therapy, start with atherectomy or balloon first, and then see if you can achieve, then you go ahead and do a laser? The second question, when you can cross with the catheter with just using saline, do you have any experience by mixing saline with contrast? Thank you.
Who wants to take the question on thrombus?
Okay. So from our first 100 cases, around 30% of those cases were in STEMI with a large thrombus burden. All those arteries were totally occluded with thrombus, with a large thrombus. And what we realize, our strategy here has been to use either a 0.9 or in some cases in a very proximal LAD or right at the ostium, even take a 1.4 fiber. The trick is to go extremely slow. And what we've seen in these 30 cases is that we've had rapid establishment of a TIMI3 antegrade flow. What we don't see is dislodging thrombus retrogradely and putting it back into the circumflex and getting it out. And, I've not seen that. What is important is after the laser pass, I still rely on using IVUS to see the residual thrombus burden. And at times we've had to keep these patients in ICU and not rapidly put in a stent in there to avoid slow flow, but get them back in 3 days and the thrombus really clears up. And if there's very little residual thrombus, it becomes a regulation angioplasty after that. That's our experience.
So what was the second question? Yeah, go on. Yes, about contrast.
Second question. First, I start, as described before, only with a saline, of course. And if my catheter, laser catheter, is not crossing by the lesion, of course, I'm starting with a contrast mixed, if actually off-label, but I hope it will be changed. We start, I personally, I have quite good experience, quite a lot of patients with it, with 10%, 25% contrast mix, up to 50%. Why the numbers are like that? Because during the data, the physical data, we know the cavitation effect is the most pronounced from 25% up to 50%. To giving more contrast is going not better in a term of physics and a term of energy, because we are thinking about energy, okay? And the safety data is that this situation must be, the lesion must be stentable, okay? We are not going distally with 2 or 1.5 millimeter of the diameter of vessel, but it's a normal for PCI, of course, the same. And after the passage with the contrast mix, the results, it's a really over 90% of success. And what is a mandatory, what Curiti said before about thrombi, in laser catheter angioplasty, IVUS is mandatory, because we just check what we can do, what happened with a laser, what laser did inside of a vessel, and just to calculate very carefully the diameter, the real diameter of a vessel.
Thank you. Peter, any comments?
I'll just make two. Are you going to show a slide? Yeah. Well, you stop up and show your slide. I'll just make two comments about particularly about saline. So, I mean, for 90% of the cases you're going to be using saline, and that keeps it safe. So I think it is contrast. I think will change. You're learning it particularly under expanded stent. You need the amplification. James has done some great experiments, and he's given us that information about how many atmospheres you can get to, which is fascinating. And I agree, we need to adapt this technique. But I think for you out there who are learning the technique, stick with saline. Advanced users can use the contrast mix. And the other thing is, I think, going back to the wire, the benefit of having a wire, of course, means you've got direction of travel. Mohammed is like one of the best operators I've ever seen in the world, having done cases with him. So I wouldn't advocate going and using it without a wire in your own home kind of lab. So I hand over to Mohammed to wrap up.
Yeah, thank you. That's a very important thing. Yes, I'm not advocating that. It takes a lot of experience to be able to use it with data wire. This is off-label. We're not here to discuss this. We're not here to tell you to do it. And the same thing with contrast. Technically, it's still off-label. However, it's been used all over the world, and it's very safe. And hopefully, in the next few weeks, you will, because we're a consensus document, hopefully will be presented. And also, there'll be some clinical data collection to show the safety of laser. So we'll come to that another time, hopefully. But basically, what we have seen in this session, that really laser atherectomy is quite effective, and it has a multifactorial effect, 3 mechanisms of action that allow you to change the complexion of any lesion, debulking it, and also cracking the hard lesion. And many times, as we've seen the show of hand, a lot of you have tried multiple techniques that we all know, the small balloon, extra support wire, and guide extension is still unsuccessful. And the only way to do it is by using the laser, because you could do it at any angioplasty wire. Once your angioplasty wire has passed, you know that the laser will be able to allow you to this. Also, you've seen the setting where the fluence, the energy that's delivered at the tip of the catheter, and the frequency. And the 0.9 catheter probably does a lot more than 90% of the cases, because it gives you the highest energy and the highest frequency, which is 80-80. Similarly, it is the versatile use of it. The most important use, to my mind, is the uncrossable lesion, and all of you have had this experience where you put the balloon and nothing passes. Undilatable lesion, again, you put the balloon, still dog bony, you can't dilate it, even with high pressure, non-compliant balloon. Laser will work like a treat. And similarly, in-stent restenosis or under expanded stent. Of course, there's the thrombus and other indication, but these are the main 4 or 5 indication. And of course, really, often people talk about cost and about laser is expensive. You think about the time you spend trying to cross uncrossable lesion. You think about the equipment. Your balloon are expendable. You paid for them. They're on the shelf. You could take 10, 15 balloon. And I've seen some cases, 23 balloon used in one case because the lesion is not being crossed. 23 balloon. Put these together, they're more expensive than 2 laser catheters. The point is, if you think you have uncrossable lesion, you have a wire through, the laser catheter will help you to overcome this, and it should be an upfront tool if you are able to have it, and I think probably you should think about having it because it's always very helpful. We are treating more and more elderly patients with calcified, difficult arteries. We are seeing a lot of unstable angina, an unstable patient where you haven't seen the anatomy. You put your wire through and you end up having to struggle to cross the lesion or to dilate it, and that's where laser could come very handy. So I hope by the end of the session, all of you have kind of seen how it can be used and understand the indication. It's not a rocket science. You learn it easily, and it is very effective, and it will allow you to kind of perform your procedure in complex cases and achieve a really successful outcome and better for the patient. And thank you very much.
Thank you. Just a quick poll. Hands up how many of you want to use laser now you've heard how simple it is to use. A few hands. Okay. So the Philips team are here. They'll be taking orders. It's not that expensive. Have a There aren't really many too. I think as long as you've got a wire through the lesion fully, we've discussed, that's really, there is no, tortuosity can be, if it's really extreme, maybe really heavy calcification, it may not be the very best device, but there's no major contraindications.
Just a quick comment about the CTO. We all know that when we cross the CTO, our wire is not always in the true lumen. It goes in and out. But it's just important to make sure you could use it in subintimal space, but I wouldn't go gung-ho and use contrast without knowing where I am. All what you're trying to do is to cross the lesion and establish flow. Then you know what you're doing, and then you could use the laser. But without knowing where you are, it's a little difficult.
Experience in our center, we performed also in subintimal, but we should to be sure that the subintimal lumen is not so longer, because it's the risk of the perforation. And as you say, we in subintimal we never perform it with contrast, just without any infusion, to avoid the extension of the dissection in the downstream of the vessel. And that was always successfully.
Perfect.
Thank you.
One quick question, because we have to close the session.
Thank you very much. Maybe I don't understand, but put a question. After you it's necessary to flush the contrast after you check it, what happens? Necessary to flush with saline, total contrast? From edge of catheter, laser catheter. After me, please.
Well, I mean, the kind of the indication or the license to use it in saline. So that's still the teaching, and that's still what we do. Often these cases are really resistant and difficult to treat. So having a little bit of contrast in there when you're trying to lase is not the end of the world, and it does help. And this is why we're trying to advocate and teach people slowly that you could have contrast on board and you could affect the lesion more in these kind of condition. However, the teaching up till now in the license to do it in saline. So you flush, get rid of the contrast completely, then you lase. And in 90-95%, as was mentioned, it will be successful. And the other 5 to 10%, you will have to use contrast or blood. Because even blood itself, if you're not flushing, could still give you a little bit more cavitation, more effective, the laser, than saline on its own.
If you not flush, you have chance to have an explosion. It's very necessary to flush the contrast with saline. Other question, if you do, it is last. From my experience,
yeah.
When you put the catheter and can go away with guide wire, consider that is total occlusion and not possible to open it. I say what I make. Very careful. 1 millimeter go and force it. And the majority of time, this is opened. Because in atheroma, have a capsule which is very, very heavy. And if you can open with the laser, you can go. And we know that the total artery occluded, not occluded really, segmental occluded. You agree this?
Well, I mean, you're not going to be using any equipment unless you're sure where your wire is and what you are going to do is safe, whether laser or any other equipment. So you're right. If the wire is in the right place and use it proximally, then you could use it distally if you know you are in the right place. If not, you're going to have to reassess and not cause any harm. So yes, absolutely.
So I think we'll just close the session now because we're going to have the next crew get in here. Thanks, everyone. Thank you.